week 4 of Functional Neurology Club. This is our 3rd lesson, so just so you're keeping in track with us week to week, if you kind of are getting lost in this online school of what week it is. This week we're covering the vestibular system, eye movements, and VOR. So it's a really important week, so make sure you're paying attention and that you've gone over the previous week so that you can be caught up to understand this week's information. Some quick announcements. Check out our Instagram, LifeUFNC. If you don't already follow us, go and follow us. You can open it on your browser if you are on a laptop or on your iPad, pull it up on the app. But we posted some pictures this week that might be helpful in copying down so that you can follow along with us and just have an idea when we're going through the canals and the eye movements, just to give you a picture of what we're doing. And also subscribe below, so click subscribe and like our videos so that you can easily keep track of them week to week. So our goals for tonight, we're going to cover just the basics of what is the vestibular system, talk about some of the anatomy that makes up this system. We're going to cover eye muscles and their innervations so that we can build the pieces of our VOR, which is our Vestibular Occular Reflex. So first we're going to learn about the vestibular system, add in our eye movements, and then we're going to understand the VOR. Then we're going to bring in the vestibular system component to our Neuro Loop that we've been working on every week. And then we're going to give you guys some clinical relevance of why this system is so important for chiropractors and how you can use the vestibular system in your patient rehabilitation. So this is the big picture of where we're going with club this quarter. This is what we want you to understand is these functional connections and loops in the brain. So don't be scared of this picture because you actually know more than you think. We've already gone over soma, so that ipsilateral body connection to the ipsilateral cerebellum, and we've been talking about this connection between the ipsilateral cerebellum and the contralateral cortex. So you already know 3 big pieces of this chart. So this week, I want you guys to just pay attention to these triangles on either side. We're adding in the vestibular system. We're going to be talking about the vestibular system's close connection with the cerebellum, and then in the coming weeks, we're going to add in vestibular system's connection to the PMRF when we do autonomics. We're going to add in a little bit of our brainstem with our eye movements today, and all in relation to this vestibular. So we're building in this part of the loop. So keep that in mind as we're going through everything today. So let's get started with some anatomy. This is our ear. I hope you guys could recognize that much. So in our ear, we have 3 main divisions or parts that we like to think of. We have the outer ear, the middle ear, and the inner ear. The middle ear has our bones that we know are associated with part of our auditory system. And then our inner ear has this structure right here, which includes the cochlea and our vestibular apparatus. So today, when we're talking about the vestibular system, I want you guys to be thinking about the inner ear. That's where we're talking about. So the vestibular system, like I said, is in our inner ear. So this is the structure that we see. This cochlea that is attached is part of our auditory system. So don't worry about it today. We're not going to be talking about that. When I say vestibular system, we're talking about 2 main parts. We have our otolithic organs, which together are the utricle and the saccule. They're sometimes called the vestibule when they're put together, as well as we have our 3 semicircular canals. So these are the main divisions of our vestibular system. And actually, before we move on, let's just give a quick definition of what is our vestibular system so we can have an understanding before we dive into the anatomy. So just briefly, our vestibular system is the sensory system that we have. We talked about it as some of our 3 main sensory systems that we have in our body, week 1. So the vestibular system helps us to detect motion, head position, and it helps to orient us in space. So it's really important in stabilization of our head and our body as we're moving through space and just moving. And it's really important in keeping us balanced. It works really closely with the cerebellum, like I just mentioned earlier. And it's just important in head positions and maintaining our posture. So it works really closely with our spinal system as well, which Rope is going to be able to get into a little bit later. But keep that in mind when we're talking about the vestibular system and those functions that it has, how important that can be to us as chiropractors when we're looking at patients who might have a problem in this area. So our otoliths. The first part of our vestibular system, our otoliths, we have two of them bilaterally, so we're going to have a utricle and saccule on our left and our right side because we have two ears, so we have two inner ears. But our otoliths are responsible for translational movement. So the utricle, I want you guys to think of that as linear or horizontal movements. An easy way to picture this is if you're sitting in your car and you're not moving, you put it in drive and you start going forward, 0 to 60. That acceleration, that linear acceleration, is detected by our utricles. And our saccules help us to detect vertical movement. So another easy way to think about this is going up in an elevator. So if you've ever been to Disney World and been in the Tower of Terror, the saccules help us to know when we're going up and also help us to detect that sudden drop when we're going down, so we know where we're moving. These systems are incredibly important in helping us to recognize gravity in our world. And because of the constant downward force of gravity on our systems, the otoliths are constantly firing. So even when we're not moving up or down or horizontally, these systems are always firing to help us know when we are moving or when we aren't moving. And another function of the otoliths is to help us orient ourselves with our head position. So if I flex my head forward like this, or I bring my head back like this, it helps me to know that my head is no longer in neutral. Because of that gravitational force and the shift in our otoliths, we can understand where our head is in space. So just this picture for you guys is to understand our utricles do mainly horizontal movements or linear, and our saccule is that vertical movement. So the anatomy of them inside is very similar, but what makes them helps them to detect different planes of motion is their orientation within our ear. So let's take a look inside into our utricle and saccule to understand how this motion is happening, how we're actually detecting this. So in our otoliths and saccules, our utricles and saccules, we have these things called otoliths that lie at the top. So you can think of these as like little pebbles that lie on top of this jelly-like substance, which is going to be our otolithic membrane. And inside this jelly-like substance, we have hair tufts or cilia, we have hair cells, and these hair cells connect to dendrites that go into our cranial nerve 8, our vestibular cochlear nerve. So what's happening in this system is when we make a movement forward or horizontal or vertically, there's a shift. That shift in gravity is causing these otoliths to move. So as we move our head or as we move in space, these otoliths' position are shifted. The rocks move. And this movement causes a shift in this jelly-like substance to move with it, which then also will move the cilia and the tufts inside. And this bending and movement of the cilia is what helps our hair cells to be activated. They know that we are moving. And so when the hair cells are activated, neurotransmitters are going to be released that will cause the depolarization of our cranial nerve 8 to tell our brain that we are moving. And this is how that orientation happens from our inner ear to get that signal into our brain. So this is just showing an example of that. When we have are going from our head upright to flexing our head forward, you can see the shifts of the otoliths, which is shifting the membrane and shifting the hair cells inside to get that neurotransmitter release and that depolarization to let us know that our head is no longer in neutral. So the second important part of our vestibular system is our semicircular canals. So those are those 3 loops that we saw in the vestibular apparatus, and we have an anterior, horizontal, and posterior canal. So whereas the otoliths were responsible for helping us to detect translational movements, the main function of the semicircular canals is to help us detect any angular movements, so anything that's not perfectly straight. The horizontal canal helps us to detect angular movement in the yaw plane. So you can think of it as rotating, like looking left and right is our horizontal canal. Our anterior canals help us to detect angular movement in the forward pitch. So think about moving your head forward at an angle like this. And posterior canals help us to detect angular movement in the backwards pitch. So think about moving your head backwards in an angle. These systems, the canals, are not constantly firing, but it's pretty dang close. They're firing 100 times a second, even when we have no motion, to help us know that we are not moving. So they're constantly firing, so we're constantly orienting ourselves to knowing where we are in space. So this is just a really great diagram. This is one of the pictures that we posted on our Instagram, so you guys can have this pulled up throughout the lecture to reference back whenever you need it. This is showing all of our different canal positions, and it has them listed to show where the head position is, then the name of the canal, the eye movements associated with each canal, and the eye muscles that make those movements, as well as which cerebellum is associated with that canal. So don't worry about all of this stuff for now. We first just want to be able to get those head positions. So actually, let's see, sometimes it can be hard to see the head positions with that bright screen. So I'll go back to it so you guys can look at it. But for now, let's just learn the canal positions. So the easiest way to do this when you're first learning, I think, is to use these moose ears. So please do it with me at home so I don't just look silly by myself. But you put up these moose ears, and so when you're trying to get into the right anterior canal, you're going to move your head down and left, which is like taking your right hand and moving it forward, right anterior. To move into your left anterior canal, you're going to take your left hand and move it forward, which is bringing your face down and to the right. To get into the right posterior canal, you're going to take your right hand and move it back. So your head is going back and to the right. To move into the left posterior canal, you're going to take your left hand and bring it back, which is moving your head back and your face to the left. And then the horizontal canals, you don't need moose ears for, they're pretty easy. For the right horizontal canal, you're just going to look to the right, and the left horizontal canal, you're going to look to the left. So those are our head positions. So I want you guys to be practicing that. We're going to have a breakout really soon for you guys to do that. But just to touch on the cerebellum associated with the canals, it's super simple. Anything that is named a right canal, so our right anterior, posterior, and horizontal, are all associated with the right cerebellum. And same thing with the left. So our left posterior, horizontal, and anterior canals are all associated with the left cerebellum. So just for you guys to have that piece of information. So now that we know these basic positions, I want you guys to understand this important concept as well. The way that our semicircular canals work is that they are paired together. So it's this constant push-pull of these paired semicircular canals that helps us to know where we are moving in space. When one is activated, its pairing is equally and oppositely inhibited. So when we are looking at a patient that might have dysfunction in one of these canals, it is extremely important that we determine, is it one canal that's firing too much, or is it the other canal that is not being inhibited properly? So we constantly want to be thinking about this push-pull that is making this system work well together. So the pairings are the left and right horizontal. So our left and our right horizontal canal, when you're activating one, so if I'm activating my right horizontal canal, right now I'm inhibiting my left horizontal canal to let my brain know that I'm using my right horizontal. And then our other pairs, you can think of them as diagonals. So there's a right and a left paired together. When I'm activating my right anterior canal, I am inhibiting my left posterior canal. So if you want to just use your moose ears still, you can think of it that way, or just move your head back and forth like this. And when I am activating my left anterior canal, I'm inhibiting my right posterior canal. So think of it like this. And if you need a little mnemonic or something, you can remember RALP and LARP, which are kind of funny. But think about this push-pull when you are looking at your patient's canal systems. So now let's do a mini breakout. You guys can pause the video here, and I want you to turn to a partner and teach them how to do the canal position. So use your moose ears or try doing it without your moose ears to just remember and name each head position as you're doing it. Another really great opportunity during this breakout would be to put a partner's head in each of the canal positions so you can practice how you would do it on a patient. I hope you had a great breakout and you were able to name the canals and perform them on a partner, or at least if not, just practice them in the mirror on yourself. So like I talked about earlier on that big chart, there are eye movements associated with each of the canals. And so in order to understand those eye movements, we need to understand the eye muscles and innervations. So we need to understand how and what is moving those eyes. So there are 6 eye muscles. So in order to learn these, I want you guys to take out a piece of paper or your iPad or whatever you're using to draw, and draw 2 eyes and draw 3 lines on either side of the eyes so that you can try to remember them. You've probably learned the eye muscles before in school, so before I just give you the answer, pause and see if you can fill out this chart labeled correctly to know which eye muscle is moving the eyes in which direction. So here's the answers. So we have 6 eye muscles. Our medial rectus is responsible for adducting the eye. Our lateral rectus on each eye is responsible for abducting the eye. Our superior rectus is responsible for elevating our eyes in abduction. Our inferior rectus is responsible for depressing our eyes in abduction. Our superior oblique is responsible for depressing our eyes in a deduction, and our inferior oblique is responsible for elevating our eyes in a deduction. So this chart is where your arrows should have been, or your 3 lines on each side of your eye. So the oblique, superior oblique, inferior oblique, and medial rectus should have been on the medial side of each of your eyes, and the superior rectus, lateral rectus, and inferior rectus should have been on the lateral sides of your eyes, which is the functional positions for our eyes, for our eye muscles, or how they would move our eyes. So although we use this chart functionally to help remind us where our eye muscles move our eyes, as you can tell, superior oblique is on the bottom and inferior oblique is on the top, which seems like it would be a mistake or a misnomer, and it can be really confusing for a lot of people. So I want to explain that. So the reason is they're named for the anatomical position. So our superior oblique actually comes from the back of the eye, wraps around the trochlea, and it attaches to the posterior portion of our eye. So it is attached superiorly, but because it is attached to the posterior portion of the eye, when it is pulled, it pulls the back of the eye up, which pulls the front of the eye down. So this is how it depresses the eye. And then the inferior oblique is a unique muscle because it doesn't come from the back of our eye. It actually originates from more of the medial portion of our eye and the inferior portion of our orbit. So it's coming from right beside your nose. So think of it as being pulled, so it's coming from the bottom and it attaches on the posterior inferior portion of our eye. So when it is contracted, it pulls the back of our eye down, which is going to move the front of the eye up. So that is how it elevates the eye in adduction. So I want you guys to make that connection. So this is showing our inferior oblique coming medially and wrapping around. This is our right eye, just to orient you. So if this was our nose, it's coming medially to the back of our eye, and our superior oblique is attaching on the top posterior portion of our eye, and it is so it's wrapping around this way on the top portion. So now I'm going to show you guys the eye movements in a functional 3D way. So personally, I think this is the best way to learn eye movement so that you're not just memorizing them. And if you just do this once, It'll help you so much to understand the anatomy of the eye muscles, to understand where they're all coming from. And once you can picture the anatomy, it helps you to understand the function really simply. So you're not having to memorize it, you're just going to understand it. So to make an eye, the best way to get something to move, you can use one of these nice cans of disinfectant wipes that you probably all have because of the coronavirus outbreak. So use that Lysol can that you've been hoarding, and then add a bowl or a paper plate or even a piece of paper to make your eyeball on the front. And then once you've done that, find a piece of cloth. It can be a long sleeve t-shirt sleeve. I'm using an OPK strip folded to act as your muscle. And just to orient you guys, this is my nose, and I'm going to be the right eyeball as I'm moving the eyes to teach you. So let's start with our medial and lateral rectus. I think those are the most simple, and their name makes sense for what they do. So the lateral rectus is on the lateral portion of our eye, and it's going, when it is contracted, it is going to pull the eye into abduction, going out. Our medial rectus is on the medial portion of our eye, and when it is contracted, it is going to pull the eye into adduction, pulling the eye in. So now let's go next to our superior rectus. So the eye muscles actually come out at a little bit of an angle. So when you're placing it, place it at the top as if it is attaching on the top portion of the eye, and pull it as if it's coming from back here. So when you put the superior rectus, when you put the eye into abduction and you pull on the superior rectus, it is going to elevate the eye when you contract. When you put the superior rectus into a deduction and you pull, it is going to encyclotort the eye. So it's going to roll the eye in. So I'm going to talk about encyclotorsion and excyclotorsion, and if those are unfamiliar terms to you, think about it as when encyclotorsion and excyclotorsion, the easiest way to see it and think about it is when you're moving your head back and forth, just laterally flexing. Think about your eyes turning in your head to keep the horizon level. That's that encyclotorsion and excyclotorsion of our eyes. So in adduction, superior rectus is encyclotorting the eye. Okay, so now inferior rectus. So let's attach our muscle on the inferior portion of our eye, and we're going to be pulling from the back when we contract from our origin. So now when I bring my eye into abduction and I contract my inferior rectus, I'm pulling the eye down, the front of the eye down, so it is depressing in abduction. When I bring my eye into a deduction, and I contract my inferior rectus, I am going here. It'll actually be easier if I do it this way. And I bring it into adduction, and I contract. I'm going to be excyclotorting my eye, so turning my eye out. Now let's get to the obliques. They can seem a little bit more complicated, but they're not. We're going to make it easy. So our superior oblique, remember, attaches to the back portion on the superior part of our eye. So posterior superior portion. And it's coming from the back of our eye, but because our superior oblique wraps around our trochlea, when it's contracted, it actually acts as if it's being pulled from the superior medial portion of our eye over here. So when we put our superior oblique into abduction and we contract our muscle, we are intorting the eye. And then when we bring our superior oblique into a deduction, we are going to see that we are going to be pulling the back of the eye up, which is going to depress our eye. So that is how the superior oblique is depressing the eye. It's pulling the back of the eye up, which is bringing the front of our eye down. And then our inferior oblique is unique in the fact that it's coming from that medial portion of our eye. So think of it as coming from right here on the inferior portion of our orbit, medially, so towards our nose. And when we pull on this muscle, when it is going in abduction, our inferior oblique is going to excyclotort the eye. And then when we bring the eye into a deduction, our inferior oblique, when we pull, is going to pull the back of the eye up. So that is how our inferior oblique is elevating the eye in a deduction. So I hope that makes it a little bit more clear for you guys and helps you to understand what our eye muscles are doing, because if you understand their position and you play with it in a 3D model, it'll help you guys to really understand it. So each of our eyes, each of our eye muscles, superior rectus, superior and inferior oblique, all have the ability to elevate and depress the eye, encyclotort or excyclotort, depending on their position, if they're in AD or abduction. So this is showing what I just went over in a picture form. So it's showing how the superior oblique is, or the superior rectus is going to this is wrong. So this is talking about our superior oblique is going to depress our eye and encyclotort, and then this is talking about our inferior oblique excyclotorting and elevating the eye, and then same thing with the rectus. But the main point of this picture that I want to show you guys is this is that aerial view of our orbit, so we can see our eye in it and all of the muscles coming in at an angle. This is again our right eye, just for us to have orientation. But so you can see from the aerial view, when you're pulling the muscles, what it's looking like and how it's moving our eye. So shortcuts to make this a lot easier for you guys. So I made you learn it the hard way first, but now we're gonna actually make it easier. So as you guys know, hopefully your eyes are yoked together so that when I look to my right, both of my eyes move towards the direction that I want to look. So our eye muscles are going to be paired together. Although our eyes are moving in the same direction, it's not the same muscles in my right and my left eye that are moving my eyes to the right. They're different muscles. So if I'm using my superior rectus on my right eye to look up and to the right, then I have to be using my inferior oblique on my left eye. A superior muscle is always paired with an inferior muscle, and our rectus muscles are always paired with our oblique muscles. So if you can just figure out the muscle on one eye, with our shortcut, you can figure out the other muscle being used in the other eye to help you make it a little bit quicker. So the exception to this rule is our medial and lateral rectus, which are always going to be paired together. If I'm looking out to my right, my lateral rectus on my right side is going to be paired with my medial rectus on my left eye. And then another shortcut to make the encyclotorsion and excyclotorsion easy for you guys is superiorly named muscles are going to intort the eye, and inferiorly named muscles are going to excyclotort the eye. So now we're going to do a breakout with our V and G, so you can see the exact eye movements that happen naturally when we move our head into these different canal positions. So we're going to show it to you guys, and if you want to practice along with us or pause the video after to practice naming the eye muscles that are used when we put our head into those different canal positions, it'll be really great to keep building on this information. All right, guys, welcome back to our breakout with the V and G. Thank you, Vrope. He's the one in the goggles here, if you didn't recognize him from last week. So this piece of equipment is called VNG, which stands for video nystagmography. It's kind of a long word, and this equipment is very amazing, cool, and expensive. So you might see it in a lot of different chiropractic neurology offices, as a lot of them like to use eye muscles to look at minute changes in our nervous system, as they can really be the windows into the brain. This is an amazing piece of equipment that helps us obviously to see the eyes on a really big scale, so we can catch those minute movements that might be harder to see when we're just looking into a person's eye, as well as graphing differences and recording it so we can go back to it and measure progress. But I do want to make the note that although this piece of equipment is amazing, and if you have the chance to do it, to purchase it because you want to work with maybe a lot of athletes who have concussions, or you want to just use a lot of neurology in your office and utilize eye movements a lot, this would be a great investment for you. But there are also Other programs that, like Right Eye is very popular as well, or you can use the classic just looking at a person's eye with your own eyes for free. That takes a little bit more training to see all of it, but you can completely do that if that is something that you want to use. You want to have more of a low-tech office, or while you're building up your practice to keep it more low overhead, definitely at least just look into your patient's eyes if you don't have this piece of equipment. Another just kind of funny shortcut that I have seen in offices is one office that was really low tech just bought a pair of like $20, $30, they were 3D goggles on Amazon, and so basically it was like 2 magnifying glass goggles to make the eyes look really big when the person had the goggles on instead of this camera. So there's a lot of cool shortcuts to look at the eyes, but this is one of the best ways. So this is what we're going to use today. So we just learned our canals, and we learned our eye movements associated with the different canals. So we're going to practice them together to see which eye muscles are activated. So you want to ask your patient to look straight forward to find an object while removing their head. So let's start with just the horizontal canals. When we move our head in the right horizontal canal, you can see that Rope's eyes went to the left. So he's activating his left lateral rectus and his right medial rectus. And same thing when we bring him into his left horizontal canal, we're using the lateral rectus on the right and the medial rectus on the left again. So now when we bring him into an anterior canal, let's do the right anterior. His head will go down and to the left. His eyes are going to be looking up and to the right. So when we're looking up and to the right, we're using the superior rectus on our right side, and the inferior oblique is the pairing on our left side. And then same thing if we were going into the left anterior canal, we're using that superior rectus, inferior oblique again. So now let's do our posterior canals. When we move our head into our right posterior canal, we're going to see that the eyes go down and to the left. So in our right posterior canal, we're using our left inferior rectus and our right superior oblique to have our eyes go down and to the left. And in our left posterior canal, we're bringing our head back into the left, and our eyes are going to go down into the right. So our eyes will be using the right inferior rectus and the left superior oblique. So I hope you guys could keep up with all of those eye muscles being used and see it was helpful to see the different eye movements that happen with each of the canals in our VNG. All right, so let's keep going and learn the innervations. Okay, perfect. So now that we have seen really clearly the eye movements that are associated with each of these canals, let's learn what parts of the brain, what cranial nerves we are using to activate these eye muscles so that we can have a better understanding into what parts of the brain are being activated when we utilize these canals, as well as when we use the eye movements with the canals. So I'm sure you guys have learned this in school before, so we're just going to go through this quickly. Our medial rectus, superior rectus, inferior rectus, and inferior oblique are all innervated by our cranial nerve 3, the ocular motor nerve. And then our lateral rectus is special. It is innervated by cranial nerve 6, the abducens. And our superior oblique is also special. It is innervated by the trochlear nerve, cranial nerve 4. So an easy way to remember this is that this rule that we learned in school, SO4, LR6, all over 3, which means superior oblique, cranial nerve 4, lateral rectus, cranial nerve 6, and all of the rest of them are cranial nerve 3. So I made up this drawing for you guys. Hopefully you can see it well. To orient you, this is going to be our right side, so the eyes are looking towards the right, and this is our left. So this is showing those eye positions associated with the canals. If you want to screenshot this, we also included it on our Instagram for you guys, so you can go back and reference it there. But this is a shortcut I made so you guys can make the innervations of the eyes and those eye movements with the canals really simple and quick. So when we're moving our eyes in the right anterior canal or the left anterior canal, when we're looking up and out, we're going to be using our superior rectus and inferior oblique. So we're using cranial nerve 3 in both eyes to activate those eye muscles to have our eyes look up in abduction. So just think when you're thinking anterior canals or looking or elevating your eyes, you're going to be thinking cranial nerve 3. And then in any of the horizontal canals, when you're looking out with one eye and in with the other, you're going to be using cranial nerve 6 for that lateral rectus and cranial nerve 3. So which eye is using which 6 and 3 is different, but for your horizontals, think cranial nerve 6 and cranial nerve 3. And then for your posterior canals, notice this is the left posterior looking down into the right, and this is the right posterior looking down into the left. You're going to be using your superior oblique and your inferior rectus, so you're going to be using cranial nerves 3 and 4. So anteriors 3-3, horizontals 6-3, and posterior 3-4. So you can just kind of draw that in. Hopefully this makes it a little bit clearer and it's a nice shortcut for you guys. So here's some more shortcuts to help with these innervations. When we start getting into which areas of the brainstem, which side of the brainstem these cranial nerve nuclei are on. So when we're using our superior muscles, so superior rectus or superior oblique, they are going to be innervated by the contralateral brainstem. And when we use our inferior muscles, medial or lateral rectus, they are innervated by the ipsilateral or same side brainstem. So don't worry about that too much now. Verope is going to go into these pathways and help draw them out with you guys to make it really clear, but maybe jot down these rules or think about them so when you go through those pathways, these are going to come back and you'll understand how they make things a lot easier for you guys. And here's that other shortcut for innervations, SO4, LR6, all over 3. Okay, perfect. So now we are going to hand it off to Verope to really tie together everything that we've learned so far. So these canals and these eye movements, and bring them together into our vestibular ocular reflex to explain what it is and how our vestibular system, our cerebellum, and our eye movements can all come together and coordinate. He's going to really do a great job. So let's get started with that.
All right, so let's continue. So what I'm going to do for you guys, I'm going to talk about the VOR, the Vestibular Occular Reflex, and how the vestibular system is connected to the vestibular nuclei to control your eye movements. Okay, before I do that and before I jump into the specifics about that system, I'm going to talk about this big picture of why we really care about the vestibular input that's coming in, the visual input, the cerebellar input, and how it all modulates together. So last week we already talked about the vestibulocerebellar system. So we know that the flocculonodular lobe, the vestigial nucleus, nodulus, and uvula are really connected to the vestibular nuclei in the brainstem. And when we talk about the vestibular system, we might be talking about the peripheral or the central vestibular system, or both. So here's the thing. The vestibular apparatus is considered to be the peripheral vestibular system. The vestibular nuclei, which we have 4 of those, superior, inferior, medial, and lateral, is going to be our central vestibular system. And that's located in the brainstem, okay, in the pons and in the medulla, in the pontomedullary junction, okay? So the vestibular nuclei is going to receive afferent information from the vestibular apparatus, from proprioception with the cerebellum, from your spine, from your neck, from your feet, from your mechanoreceptors, and also input from the visual oculomotor system. Okay, so all these things fire into the vestibular nuclei, so we can create appropriate motor output to navigate and move in the world around us in this 1G gravity environment. Okay, and that's really, really important for our survival. So first of all, let's start talking about the vestibular apparatus. So the information from the canals and the otoliths come into the vestibular nuclei. You don't have to worry about which one specifically now. Just call them the nuclei, vestibular nuclei for now. And come in, and 20% of that input will go into the eyes and control the eye movements. And 80% of this input from the vestibular apparatus into the nuclei will go into your postural stability, 80%. So as a chiropractor, you think that might be important? Absolutely. And here's the thing. The vestibular apparatus, like we already mentioned, is firing all the time, okay? There's about 1.5 5 million action potentials entering your vestibular nuclei and your brain from your vestibular apparatus at any given second. Okay, 1.5 million action potentials. Now, so if you have a faulty system, or if you're not getting appropriate stimulation or activation from the vestibular system into the nuclei, your postural muscles are going to be torted as well. They're not going to be functioning as well. There's going to be an issue in that system. And the cerebellum comes in and says, hey, this is not cool. This is not what's supposed to happen. And it's trying to fix this problem. Like I talked last week, the cerebellum is this error corrector, and it's taking all the proprioception from your body and making sure that whatever comes into the body and leaves the body is happening in a most appropriate way as possible. Okay, so 20% goes to the eyes, 80% goes to the postural system. So then we have connection from the eyes to the vestibular nuclei as well. So the visual input around your world is going to give your vestibular system and your vestibular nuclei a lot of information where you are in space and how you should navigate in the world. It's all about how you perceive gravity. And the thing that Rebecca already mentioned is that the vestibular system is the most primitive sensory system we have. So all the other sensory systems built on top of the vestibular system. So if you have bad interpretation of gravity, that means that you're going to change all the other sensory systems as well. Okay, because they're counting on the vestibular system to work correctly. And the thing about with vestibular pathologies is that people who often get better from suffering from a vestibular injury are usually the people with a good cerebellar system. Okay, so the cerebellum works in a tight junction with the vestibular system. All right, so let's start talking about more about the VOR and how the vestibular apparatus and the vestibular nuclei are connected to the eyes. So what is the VOR to start off with? What's the function? Well, it's there to stabilize our vision while we're moving. So if I move my head to the left, my eyes will go to the right. If I'm jumping up and down like this, my eyes will stay fixated on a target. If that didn't happen, your eyes would move with your head movement. And that's what we call oscillopsia. And that's when you get your vision will get obscured and you will see the world moving around you. So for example, if I turn my head to the right and my eyes didn't stay fixated to the left on the left, that means that my eyes would move with the head. So you can try this out. You put your thumbs out in front of you and you move your head and your eyes the same direction. I can see that the world is spinning to my left when I turn to the right like this. So we have to have this system to be able to fixate our fovea on a target when we're moving. And we give you a good example in club always. We talk about, imagine, or for example, if you go on a run and you're filming a video on your phone, and you're running and the whole thing is bouncing, and you look at the video and the video is obviously bouncy. Well, why isn't your video, your field of vision bouncy? It's because of this VOR, okay? It has to be there to stabilize our vision. And it's a really fast system too. 7 to 15 milliseconds of the latency that system fires and happens. And the reason why it's so fast is because those vestibular canals and the otoliths are firing all the time. So the canals are firing about 100 spikes per second all the time, even though you're not moving. So when you do move, you already have activation in that system, and then you just increase the activity a little bit, and boom, you have a response. So you don't have to start all the way from 0. You start from 100 and go up from there. And then you decrease the firing on the other side. That will give you integration into the nuclei as well to tell you, hey, my head turned this way. And that's the push-pull mechanism. So if I turn my head to the left and my eyes go to the right or stay fixated on the target, that possibly meant that I had 150 spikes per second that happened fired in the left horizontal canal. And then from 100 spikes per second that we had on the right horizontal canal, it went to 50 spikes per second. So that's the push-pull mechanism that we're talking about, okay? A super fast system. So when we talk about things such as motion sickness, that's usually an issue with the VOR. So there's a mismatch between the visual input and the vestibular input. So for example, you're in a car and you're reading a book and you get dizzy or you get nauseous and you feel like you want to throw up, you can't do it. That could be because the car is bouncing a little bit every time it's going over a little bump, and your whole body is moving, and then your head is moving. And if your eyes are not staying fixated on those words and on that book, your eyes are going to move with your head, and it seems like the world is moving. And due to their really direct connection to the autonomic nervous system, you are going to get nauseous or you're going to get other autonomic symptoms. And that could be one of the reasons why you cannot read in a car, okay? So this system is absolutely important. We have to have it intact. So how do we measure if the VOR is working correctly? Well, we talk about this thing called the gain. And basically what that is this movement of the eyes divided by the movement of the head. And they should be equal, okay? So if I move my head to the right and activate the right horizontal canal, my eyes should go opposite and equal to the opposite direction, okay? If that didn't happen, let's say I move my head to the right, like this. Eyes are staying here, but in this case, what happens when I move my head like this, my eyes come with the head movement. They move with the head, okay? So I'm trying to do it slow, move my head, and then the eyes come, and then they refixate back to the target. If that happens, you get a visual or ocular slip of your environment and the world moved around you, and you could get vertigo, for example. You feel like the world is spinning, okay? So that's what we call a decrease in gain. You turn your head, you have a VOR response, but the eyes moved with the head. Then the opposite, if you have increase of gain in the system is working a little too much. I'm having a little bit too much conversation, let's say from my left horizontal canal. When I stay fixated on the target and I move my head, my eyes went past the target to the opposite direction. It went too much. The system was working too well, if you could say that. Okay, so that's a decrease in gain and increase in gain. And then once we show you how to test this, you can possibly see this happen with your friends or with your partners or your patients. Okay, perfect. And let's go to the next slide. So, VOR circuit. So, Rebecca already talked about this a little bit. So here it is. This is how the vestibular system is connected to the brainstem, and the brainstem then has or houses these nuclei that are responsible for firing into those eye muscles. So the areas that we are interested in right now is the vestibular system, cerebellum, pons, mesencephalon, and then the individual eye muscles. Okay. So I'm going to start breaking this down for you, and I'm going to draw it out for you, so it's going to be easier for you to follow. And let's go for it. All right, so let's get to it. Let's draw these pathways. So I'm going to be drawing the pathway from the vestibular apparatus and its connection to the vestibular nuclei, and then the brainstem nuclei that are responsible for moving your eyes in a certain direction. And the reason why we want to put a lot of time into this is because it matters for your therapies. So doing an eye movement horizontally versus vertically is a completely different stimulation to your brain. Specifically, your brainstem is going to be involved differently that right now we're going to be focusing a lot on. So let's start off with a horizontal canal. So how do my eyes move if I move my head to the right like this? My eyes will go to the left, okay? So I activated my right vestibular system. That right horizontal canal, those hair cells bend because of the endolymph moved and pushed those hair cells and created action potentials, and those action potentials traveled through the vestibular occular nerve, and that afferentation came into the vestibular nuclei on the same side, which then fired into these nuclei in the brainstem that are responsible for moving your eyes. So that whole pathway, we're going to draw it out for you, and it's going to make a lot of sense for you, okay? So here are our eyes, and excuse me, I'm not an artist. So right horizontal canal activation, which way will our eyes go? Our eyes will go to the left, okay? This is where our eyes are going to be pointing at. Which muscles are responsible for moving our eyes left? Well, the AB ductor will be the lateral rectus, and the AD ductor will be the medial rectus, okay? And then you can already start thinking about which cranial nerves are responsible for innervating these eye muscles, okay? Before we do that, let's go ahead and draw the brainstem. You're going to have the midbrain, the big fat pons, and then we're going to have the medulla. And then after that, you're going to have the spinal cord. All right, next we're going to draw the vestibular apparatus with the semicircular canals. There you go. Remember, we have anterior, posterior, and horizontal. Then we're going to draw the cerebellum. This is our cerebellum in the back, like this. All right. Then let's add the cranial nerves, so cranial nuclei in there. So cranial nerve 3 and 4, oculomotor and trochlear nerve, are going to be in the midbrain. We also call the midbrain the mesencephalon. Okay, so we use those two words really interchangeably, so I don't get confused with that. So then we're going to have abducens, cranial nerve 6 in the pons, and then we're going to have our vestibular nuclei. Remember when I told you that it's in the pontomedullary junction, like this, and it has 4 parts to it, so I'm going to make it like that. Perfect. So now, our eyes are going to the left, our right horizontal canal is activated. So, let me change the color here. We go from the right vestibular nucleus, or right vestibular apparatus, into the right vestibular nucleus right here, and we activate that guy. At the same time, you're going to send a collateral into the cerebellum, okay, the same side of the cerebellum. So if I move my eyes to the left, my head went to the right, that's a right vestibular, right cerebellar activity. And then what's going to happen is that these guys need to be activated. We need to fire those guys. So the vestibular nuclei is going to fire in the cranial nerve 6, which is responsible for innervating the lateral rectus. Then what's going to happen is that we're going to jump on a highway here called the MLF, which is the medial longitudinal fasciculus, and that's going to fire the cranial nerve nuclei 3, the oculomotor nucleus, and fire into the medial rectus to adducti. So abduction by cranial nerve 6, lateral rectus, and then adduction by medial rectus, and innervated by the cranial nerve 3. And then what's cool about the MLF, or diagnostically important, is that it's really highly myelinated pathway, and it tends to be one of the first pathways that gets demyelinated in MS disease. Okay, so if you have the patient, for example, let's say that this pathway was out, it got demyelinated and doesn't work anymore. Let's say you try to put the patient's, move the patient's eyes into the left. Well, what's going to happen is you're going to have abduction of the eye, but this eye will just stay still. It doesn't move anywhere. It looks pretty crazy. So you move your eyes to the left eye abducted, but right eye stays right in there. Okay, but then when you go to the right, they're both able to move to the other side. So that's how you can see if somebody possibly has an MS going on at the moment. Okay, just a little clinical gem for you guys. All right, so hope you understood what the whole pathway. The main thing I want you to take out from this is that you activated the right vestibular apparatus, which fired into the ipsilateral vestibular nuclei. And remember, whatever happens in the vestibular nuclei is going to have a postural response as well. It's also going to have connection to the autonomic nervous system and the cortex that we talked about week 2. So it communicates into a lot of different areas of the brain, and that's why it's such an important system for us to consider. And another thing I want you to take is that we get a lot of pontine activity with the horizontal eye movement. When we go into vertical, you'll see that we'll get more mesencephalic, more midbrain activity. And the mesencephalon, the midbrain, is this animalistic part of the brain. Okay, it activates the sympathetics. It has a lot of connections to the limbic system. So if somebody's really wound up, you might not want to do vertical eye movements with them. Or if they're suffering from hypertension, you might not want to do a lot of these vertical eye movements, depending on the patient, of course. But this is how you can start seeing a little bit of different bias over the other, depending on the eye movement. Okay, so then let's draw another canal. All right, so now let's draw an anterior canal position associated with an eye movement. So let's go over the left anterior. So if I go into a left anterior canal position, like you guys already learned how to do that, my eyes will go up and to the left, right? So which muscles are responsible for moving my eyes up and to the left? You already got it. Okay, so we're gonna have, I'm gonna draw it here, superior rectus, and then we're gonna have inferior oblique here. Remember, the inferior oblique is a little different because it wraps around and then pulls the eye up. Okay, so then you can already start thinking about which cranial nerves are responsible for innervating these eye muscles. All right, so we're gonna start off from the vestibular apparatus. So left anterior canal activated the left vestibular system in there. It's going to fire into the vestibular nuclei, and it's going to send a collateral to the cerebellum. Then what's going to happen is, again, we're going to cross over from the vestibular nuclei into the cranial nerve nuclei number 3. Why 3? Because the inferior oblique is innervated by the cranial nerve 3, and so is the superior rectus. And here's the rule. Remember that superior muscles are innervated by the contralateral brainstem. Inferior muscles are innervated by the ipsilateral brainstem. Okay? So cranial nerve 3 comes in, fires into this guy, and comes in here and fires into this guy, to have elevation and abduction in the left eye, and to have elevation and adduction on the right eye, inferior oblique and superior rectus. Okay, now you can start seeing that a left vestibular activity activated the left cerebellum, the left vestibular nuclei, but it activated the right mesencephalon. Okay, so what if somebody has a difference of blood pressure from side to side? Because we're gonna, don't worry if you don't get this yet, but we're gonna talk about the mesencephalic midbrain's contribution to sympathetics bilaterally and ipsilaterally. You might see a difference in the blood pressure due to firing of the midbrain or due to pontomedullary reticular formation firing differently. So I'm kind of throwing these things at you. I don't want you to get confused, but next time when you hear it, it's not going to be that confusing, or you're going to understand it better. So for our therapy, we're getting a lot of right midbrain activity here, and it matters, okay? So doing an eye movement up and to the left, it's a big cerebellar and left vestibular activity, and also the right midbrain. And this is the loop where we talk about. I move my hand on the left side, or I'm getting proprioception here. It's the left cerebello, meso, which is the mesencephalon on the contralateral side, and then you're going to have cortex, back to pons, and back to the cerebellum. And that's the loop that we were talking about here, okay? Left cerebellum, right midbrain. Cool. Then let's go into the next canal. So now let's draw out a posterior canal connection to the vestibular nuclei and to the eye muscles. All right, hopefully you're getting the drill a little bit here already. And what I want you to do actually is that I want you to draw the other side that I didn't do. So pause the video after the horizontal canal and the anterior canal, and then after this, and try to draw the other side, okay? And here's the left side that got wiped off. All right, so let's pick, for example, the left posterior canal. So if I want to activate the left posterior canal, I'm going to move my head into this direction. And which way did my eyes go? My eyes went down and to the right, okay? So let's move our eyes down and to the right. Which muscles are responsible for moving our eyes in this direction or holding our eyes in this position is going to be inferior rectus, yes, that, and then we're going to have superior oblique here, okay, SOIR. So we're going to activate the left vestibular system. Left vestibular system will fire into the ipsilateral vestibular nuclei, send the collateral to the cerebellum, and then what cranial nuclei innervate these muscles? Inferior rectus has to be 3, superior oblique is part of our rule, LR6, SO4, so it has to be cranial nerve 4. And now remember that superior muscles are innervated by the contralateral brainstem and inferior muscles by the ipsilateral. Okay, so what we're going to do is the vestibular nuclei is going to fire in the cranial nerve 4 and 3, and they're going to innervate the eye muscles. Okay, cranial nerve 4 to superior oblique, and inferior rectus and cranial nerve 3 are together. All right, so that's how it works. Hopefully you can draw the other side now. So one more time, when you move your head back into the left like this, you're going to activate the left posterior canal, eyes go to the right, and how that happens is that you get afferentation from those bending of those hair cells, and the action potentials travel through the vestibulocochlear nerve into the vestibular nuclei, and the vestibular nuclei is responsible for making that slow eye movement happen and moving the eyes, or just keeping the eyes fixated in that target by firing cranial nerves 4 and 3 for superior oblique and inferior rectus. That's how it works. And here, yet again, you can see there's a lot of bias into the midbrain, okay? Not so much pontine activity as you get with the horizontal eye movement, okay? So try to start picking up on those things a little bit. It's going to help you a lot trying to understand the future concept that we're going to be talking about. Okay, perfect. So let's continue with our conversation of combining the cerebellum, the eye movement, and the canals together. So you can see these arrows in a diagonal fashion here, and those are representing the cerebellar activity on one side over the other. And because of this contrast, you can't see me really well right now, so I'm just going to go off of this slide right now and explain it to you how it works. All right, let me go back here. All right, so you saw this diagonal line over there. So what it means is that when I move my eyes up and to the right, down and to the left, up and to the right, down and to the left, that's all a right cerebellar axis. And the reason why that is, you probably picked it up already from the pathway, is that if I move my eyes up and to the right, that eye position is associated with activating those same central neurons that integrate the information or the activity from the right posterior canal. And the right posterior canal is really connected to the right cerebellum, or the afferent information that's coming from there. Okay? And same thing, if my eyes go down and to the left, that's a right posterior canal activity, and right posterior canal activity associated with the right cerebellar activity. And then when you saw the horizontal line, so your eyes going to the left, that means that you would rotate your head to the right, and that's a right horizontal canal activity activating the right cerebellum. So that's how it works, and the same exact thing goes for the left side as well. So what we can do with that is we can use that as a part of our treatment. So I already mentioned this, I think in week 1 or week 2, is that you can couple an adjustment with an eye movement. Okay, so let's say you did all your cerebellar findings and you found that there's dysdiadokinesia and there may be a little bit not as accurate on one side or the other, and you found out, okay, this person needs a little bit more cerebellar stimulation. Well, now you know, and you can explain to whoever that why an eye activity or eye movement or eye position in certain position would activate one cerebellum over the other a little bit more. It's a bias towards one cerebellum over the other. So looking up in the right cerebellum, you could activate or you could adjust the patient on the right side to create that spatial summation and activate those neuronal pools just a little bit more. So it's really clinical, and I hope you're going to use it one day. And the opposite goes as well. If you have an adverse reaction to an adjustment, maybe that stimulation was a little bit too much to that cerebellum or to that proprioceptive system, or in general to the cortex and the brain. So what you could do is you could counterbalance this activity a little bit more. So what you could do is, let's say you're adjusting on the right side again, and you want to move the patient's eyes to the left. When you do that, what happens when you move your eyes up and to the left? Well, you get more left cerebellar activity and more right cortical activity, versus the adjustment is going to be right cerebellar activity and the left cortex. So you're kind of counterbalancing those two, so you're not getting as much activity and stimulation into that system. All right. So then, how do we test the vestibular system? So one of the first things you do, you look at posture. One of the easiest things you can do. So the patient walks into your office and they have a head tilt, for example. So let's say they have a head tilt towards the left, like this. That means that they're going to have ocular tilt as well. So their eyes are going to counter-rotate to compensate for that head tilt. And then what you're going to do, you're going to get a proprioceptive input from the neck telling you and modulating into those vestibular nuclei, telling you that, hey man, I don't think you're center. Here's center. And what it'll end up doing, it'll overcompensate to the other side. And that's why we say that the patient will often lean into their weakness. So the reason why you got initially the head tilt to the left was because you had an overfiring system of the vestibular system on the left. And then the neck proprioceptive came in and told the brain that, hey dude, you're going a little bit too much to the left, let's go to the right, and then you overcompensate to the side of weakness. Okay? You can also see that the patient will tilt to the side of hyperactivity as well. That's also a possibility, but quite often you see the patient tilting to the side of weakness. Okay? And that's called a pathological ocular tilt reaction often when you have this counter roll of these eye movements, etc. So then we're going to have the sway test. So the sway test, we already did that last week. But right now what we're going to do in just a bit, we're going to do the same test, but we're going to have a balance pad underneath the patient's feet so that we are taking off some proprioception, and then we're going to have the patient close their eyes as well, so they're not relying on their visual input that much either. So we're forcing the vestibular system to do a little bit more work, and we can see the subtle changes or the subtle miscommunication or mismatches in the system and see if there's an issue in there. Okay, and you want to look for sway in 3D. So you want to be looking at the sway in the right anterior canal plane, left posterior canal plane, left anterior canal plane, right posterior canal plane, and then maybe you're going to have horizontal sway or flexion versus extension in the sagittal plane. Okay, so you're going to be looking at it in 3D, trying to understand what's going on. Maybe one canal is overfiring and one canal is not, or maybe the central vestibular system is not integrating that information coming from those canals appropriately. And when you have a central vestibular issue, your findings might be a little bit more all over the place than from a peripheral vestibular lesion, but that might be a little bit more straightforward. Okay. So then we have a Fukuda step test. The patient, what they're going to do is they're going to march in place for about 50 steps like this and have them close their eyes. And you often see that the patient, after the 50 steps or during the 50 steps, the patient starts leaning towards the hypofunctioning cerebellum and vestibular system. All right, then we're going to have VOR. So VOR, you're just going to do different canals and see how the eyes are moving with the head or moving to the opposite direction equal to the head movement. So if I would put the patient's head in the right posterior canal, I would tell them to fixate on a target and go through all these different canals and see how their eyes are moving. Okay, are the eyes actually able to fixate? Are they coming off of the target? Is there a decrease in gain? Is there an increase in gain possibly? And see if the eye movement is actually smooth. Is there any glitches? Is it chumpy? Okay, you start looking at all these different things. Then Halmagi's, which is a head thrust test, is that you'll do it just a little bit faster. So you go like this. So you move the patient's head just a little bit and much faster. The reason why we want to stress the faster or doing a faster response or head movement is because the system is really good at compensating. So I'll give you an example. So if I do a head thrust or if I move a patient's head to the left, we already talked about this, you get more activity on this side of the vestibular apparatus. Let's say you get 150 spikes per second coming from this vestibular apparatus that initially started from 100, okay? And then now you have 50 here. Well, the thing is, even though you didn't get the information from here, the activity, the inhibition that came from 100 spikes to 50 spikes in here is already going to tell your vestibular nuclei and your central nervous system telling you that, hey, your head had to turn to the left because this side got inhibited. So what we do is we do a faster head movement, because when you do a faster head movement, that activity might go to like 300 spikes per second, okay, or 200 spikes per second. And this side, that side is supposed to be inhibited, can only go to 0. So it can't compensate anymore as much. So then you see when you do this fast eye movement is that did the eyes actually stay on the target or did they not? Did they go with the head movement or did they go past the target, which we already discussed? Okay, so let's test all these. All right, so now let's get into testing of the vestibular system. So first we talked about the posture. So you're looking at head tilts and head rotations as well. And now you want to look at the entirety. Okay, last week we talked about internal rotation of the arm and the leg. You might be looking at the facial tone, the shoulder as well. So let's just look at Rebecca, how she looks like right now. I don't see any crazy head tilts or any crazy internal rotation of the arms either. She might have a little bit of a right head tilt right now, but it's really small, really slight right now. Nothing that I'm really worried about right now. Then let's go into the sway test. So what I'm going to do is I'm going to have the patient step on this balance pad. I'm going to show you. So it's like this. It's wobbly, and it kind of takes off your proprioception. It's like foam, okay? So it's a foam pad. So the patient is going to stand up over there. Perfect. Feet together. And in a minute, I'm going to ask her to close her eyes. You don't have to do that yet. But the whole purpose of doing this balance pad is that she has less proprioception coming from her feet. And then when the patient closes their eyes, they can't rely on the visual system either. So now we took off the visual and the proprioceptive system, and now she only has to rely on the vestibular system. So we're able to bias and force that system a little bit more and see if there's any findings. So what I'm going to do is I'm going to have her close her eyes and see if she sways into any direction. She's pretty balanced. Okay, go ahead and open your eyes. So like I mentioned before, you want to look at in this 3D plane. So if she sways in the right anterior canal position, or left posterior, or left anterior, right posterior, or maybe she's just going laterally like this, or just straight into forward or backwards sway. Okay, and a cool thing you can do is you can also look at the patient's feet and how the muscles are contracting, and the patient might complain to you, oh yeah, I have pain in the lateral side of my leg. And that could indicate to you that the patient is compensating a lot in this lateral movement plane, because they're always swaying in this one direction over the other, and they're using these lateral muscles of the leg. Versus you might get more of talus could be a little bit sensitive, or you can have pain in there if they're swaying in flexion versus extension plane. So those are just a few things to consider when you're looking at this way. So then we're going to continue. So we're going to go into the different canal positions. So what we're going to have her do is to go ahead and look to the right. Perfect. And then close your eyes. And you want to be close to the patient in case they fall. Perfect. Open your eyes. So you're just comparing from side to side. So go ahead and look to the left and close your eyes. Okay, a little bit more sway there. Go ahead and open your eyes. Perfect. And then we're going to do a right posterior canal. And close your eyes. All right. Open your eyes and then go to the left posterior canal. So you go ahead and open your eyes. You're seeing how these are a little different findings from canal to canal. And that's going to kind of paint you a picture of what we're looking at here. And remember to look at the initial sway. Did they initially sway into this direction and then they compensated to the other side? So go ahead and do a left anterior canal. And then the right anterior canal. All right, quite a bit of sway there. So that's how you're going to start differentiating. So right now I was looking at a right anterior canal was causing her to sway quite a bit, okay? Then we're going to have further discussions in the which direction, and did she compensate here or here or here, and did her posture change while she was doing that, okay? So you want to look at everything that's happening at the same time. Perfect. So next, what we're going to do, and by the way, you could do the same test. It's a little different, but you could do it with eye movement. So you can have that patient close their eyes and tell them to look up and to the right, look up and to the left, or look left, look right, and see if that changes the findings either, okay? So go ahead and step off of the pad, and next we're going to do the Fukuda step test. So what I'm going to have the patient do, put your arms like this, and then you're going to start marching in place and close your eyes. And you're going to march for about 50 steps, and you start looking at if the patient is going to lean towards one side or rotate to one side or the other, or maybe there's a difference in how her hands are going to, if her hands are going to go like this, her eye will drift. Perfect. So she was pretty straight, you know, she didn't really lean to left or right that much. Sometimes you see you do 50 steps and then the patient opens their eyes and they're like, boom, whoa, I'm here, like what's going on? So like I mentioned before, you usually lean towards the hypofunctioning side, okay? Next, we're going to do the VOR, so I'm going to have you sit over here. So the VOR is the vestibular ocular reflex like we talked about. So really simply, I'm just going to be moving her head into these different canal positions, and I'm seeing if the eyes move opposite to the head, okay? And then you can also look at how the eyes are moving. Is there any jumpiness into that movement, okay? Any glitches, or are the eyes actually able to stay fixated on a target? So what I'm going to do is I'm going to have her look at my nose. And you want to be at the level of the patient. I don't think I'm exactly at the same level right now, because you don't want the patient to be looking down or looking up. Also, you don't want the patient to be in convergence or in divergence. You want to be in a good distance here. So what I'm going to do, I'm going to move her head into the left horizontal canal and look into her eyes and see how they're moving. Right horizontal, left horizontal, okay? Then we're going to do right posterior canal, left posterior canal, and then we're going to do left anterior canal and right anterior canal. Perfect. And her eyes seem to move pretty well with the head movement, or they stay fixated on the target really well. So she didn't jump off of the target, or she didn't jump over the target when we talked about the decrease of the gain versus increase of the gain. So a really simple test. But then we want to stress the system a little bit more. So we do the Halmagi's test. So I'm going to do a fast thrust. So it's going to be a fast head movement. It's going to be really small. Not going to be big, so I'm not going to go all the way here, because that's not just, we're looking at subtleties of in the system, okay? If there's any errors. Very good. So she's doing really well. You know, her eyes are staying fixated on the target in a fast head movement and in the slower head movements as well. So those are just a few tests you can do to test the vestibular system. There's a lot more to do, but these are the basics, these are the fundamentals you can do at home, and really simple to do, and gives you a great window into the vestibular system. All right, thank you.
Thanks, guys. We'll see you next week for part 2.
Bye.
Bye.